Hello, hello, everybody, and welcome to the IOCDF Research Roundtable, the IOCDF live stream where we pick a topic in the OCD research world and we discuss it with the people who know it best. My name is Kyle King. I am a second-year med student at the Yale School of Medicine, interested in psychiatry and all things OCD. But more important than that, on this stream, I'm someone with OCD. I've lived with it since I was in middle school. So a lot of the things that we talk about on this show are super relevant to me, this topic included. As always, I'm joined by my co-host, Jonathan Abramowitz. John, if you want to introduce yourself.
Sure. I'm Jonathan Abramowitz. I'm a professor at the University of North Carolina at Chapel Hill. And my research and my clinical work and my teaching focus primarily on OCD. And I am delighted, honored, and excited to hear all about today's topic from our two very distinguished guests.
Yeah, I feel like this is a special episode.
It is.
We normally don't have in-house researchers.
Yeah.
And we're normally, I don't know, I guess this is the first paper like this that I've seen in a while. But today we're going to be talking about a white paper that was recently released by the IOCDF. Correct me if I get the title wrong, the America's OCD Care Crisis. Which is kind of, I won't get too much into it, but as I read it, it was like the first, or one of the first pieces of like real world, let's dig into what's actually happening out there with folks with OCD papers that I've seen in a long time. But I don't want to say too much about it. I will introduce my guest in a second. Before I do that, I have some announcements that I just need to make. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find help to locate a trained clinician near you. The International OCD Foundation is also not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please call 988 the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org. Go to your local emergency room or call 911. Also, as always, there's a chat feature. We have some experts on. I feel like there's going to be a lot of questions about today's discussion because the white paper is super interesting and it's really applicable to folks out there in the field with OCD. So feel free to ask your questions. We want to get to as many of them as possible. Just know anything you read out there lives online forever. John didn't like something that I just said. He's gone. But it's fine. He'll come back eventually. He gets over it really quick. But in the meantime, why don't we introduce our distinguished guests? Well, actually, I'm going to take a back seat on this one. That's how distinguished they are. And I'm going to kind of let them introduce themselves. Hey, John.
Hey, sorry. Hit the wrong button.
So our first guest is Becky Deusser. Becky is the executive director of the IOCDF. Becky, if you want to say anything more about yourself.
Sure. Great. We're so thrilled to be here and talk about this white paper and have some conversation with your viewers. Been the executive director of the foundation for almost 2 years now. Before that, I worked in healthcare for a number of years with a health system called Tufts Medicine that's based in Boston. I'm also based in Boston at our IOCDF headquarters. And before that, I worked in state government and public policy for a number of years. So a white paper like this really brings together things that I'm so passionate about. First and foremost, advocating on behalf of our OCD community that the IOCDF tries to serve every day, and then advocating for access to mental health care, and then bringing that together with what we can do to affect change from the public policy perspective and by advocating and speaking with other types of decision makers in addition to that. So absolutely thrilled to be talking about this topic and being here with you.
Yeah. And as always, I have to ask a silly question. It is the last month of the year. So in reflection, what is the best TV show you watched this year?
Oh, Paradise on Hulu, hands down.
Literally never heard of it.
I recommend. We're in a different age demographic, so maybe that's why but I strongly recommend it. It's a political thriller and it's fabulous. Highly recommend.
All right. Hopefully Sanjay just watched something that I've at least heard of. But our other guest today is Sanjaya Saxena. Sanjay is let me get the title right, Director of Clinical and Research Affairs at the IOCDF. And I don't know if you'd have anything else you want to say.
Yeah, I echo what Becky mentioned. We're very, very excited. This is, I've been in my position with the IOCDF as Director of Clinical and Research Affairs for almost exactly 2 years. And I would say this project, really, that we've been working on for more than a year now, is probably the most exciting and potentially, we hope, transformational project that we've done. And so there's a lot of enthusiasm, I think, because of how important we think are and what the message is that we're trying to get out as broadly as we possibly can to policymakers, government, insurance companies, as well as clinicians and people with lived experience and family members and supporters. So in terms of my background, I've been in this position for a couple of years. I'm also voluntary clinical faculty, clinical professor of psychiatry at UC San Diego Health System. Prior to this, I was a full-time faculty there and director of the UC San Diego OCD program for quite a number of years. Prior to that, I was at UCLA directing their OCD research program. So my background has been in research, teaching, and clinical care, mostly focus on OCD and related disorders, and to some extent, more broadly, to anxiety disorder.
And don't think you're getting out of the question. Favorite TV show this year?
Yeah, I would say over the last 1 year, Andor.
I don't know that one either.
Andor is the newest in the actual.
So you're just more nerdy than I am.
But it's not nerdy, and it's actually much more political and relevant to this year's. I highly recommend. Yeah, got nominated for a bunch of Emmys and so on.
Okay, I just like to make fun a little bit. But let's get into this white paper. So it's a big document. It's dense, and we've just been calling it the white paper so far. So I kind of want to start just by asking, like, you two have probably been involved in this project since the conception. What was the initial thought process? What were the problems you were like, there's something going on here. We need to do research on this. How did this paper project even get conceptualized and started?
Sure, I can start, and Sanj, please jump in. So it goes back started in my role here at the IOCDF, where we undertook this process to develop a long-term strategy on how we can dramatically and significantly broaden our reach. We have an amazing community. We reach a lot of people, millions of people every year, but there's so many people throughout the world who don't know about the IOCDF and don't know what resources, treatment, and diagnosis, and all of the things coupled to them. And my charge is to help us come up with strategies and ways to reach many, many, many millions more people and raise awareness about OCD and about the IOCDF. So in this first year of our 5-year strategy, one of the biggest milestones and projects that we worked on was this white paper. And it came about in 2 key ways. One was that we didn't really have a baseline to think about if we want to increase the number of people who are getting treated for OCD, which is something that we feel strongly that that's one of the key pieces of our charge as an organization. We didn't even have a baseline to identify, like, are we going from 20% to 40%? Are we going from 1% to 2%? So we first conceived this paper in one way to come up with what that baseline is. And this was the way we thought about the most reasonable way to do it, was to focus on the US. Obviously, we wished we could do an even bigger white paper one day that covers other countries as well. So that was one. And we were able to do that, I think, in a very thorough, incredible way. And then 2 was with a white paper, the purpose of a white paper is to share data and information and research, but it's also to include recommendations and frame it around for decision makers, how they can help affect change to advance an issue. And many large nonprofits develop and publish white papers frequently. This is our very first one. So we think it's going to also help, as much as it helps have that baseline and us monitoring and measuring progress on our longer term goals. It will help us advocate for changes that need to happen in order not just to increase the number of people getting treated for OCD, but all the other work that we do that's aligned with our mission.
So,
Yeah.
Oh, you go, Sanjaya.
Oh, no, go ahead.
I was just kind of rephrase and say, like, the initial question was, what's our baseline number of folks who are getting treated with OCD out in the field? But when I was reading through the paper, it seemed like there was a lot there's a lot more questions that were being asked. So if that's where it started, I guess, what kind of questions did eventually you undertake in this project?
Yeah, I can speak to that. It did start with kind of an idea of that we needed just data. And in particular, we needed large scale national data. So there's been, several prior studies that have looked at, let's say, percentage of people within a particular health system who were diagnosed with OCD to try to get an estimate of how many people are being missed, right? Or undetected, or perhaps people weren't telling their clinicians about it. There have been other papers trying to get a picture of, if you have a population of people with OCD, what treatment did they get? How many, what percentage got medications? What medications? Did they get the right dose? Only a handful of studies have taken a look at what type of psychotherapy did people receive, right? We know from anecdotal evidence from people's experience that very, very, very few people with OCD actually get the most highly recommended, gold standard recommended treatments, particularly psychotherapies, which is exposure and response prevention, right? And even more broadly, if you consider cognitive behavioral therapy more broadly, we didn't really have great estimates on a national level for how many people with OCD were getting referred, how often they received it, and whether it included a specific technique of ERP. So while we had a little bit of information, none of that information was on this scale. And so our objective was to really landscape diagnosis and treatments in the United States at a broad level. And we were able to access large-scale real-world data from the Guardian Research Network. Big data sets of electronic health records. In this case, we were taking a look at what was happening over a 10-year period, 2015 to 2025, with a very large sample. So I think, we had several questions. Number one, what's the estimated percentage of people in the US who've been diagnosed with OCD? Number two, what are their demographics? What are their characteristics across the lifespan? Because very few papers have looked at the entire lifespan. Maybe they've focused just on kids or just on adults. Often they've excluded elderly people. We wanted to include everyone. We wanted to take a look at the demographics, right, of who's getting diagnosed with OCD. What are their racial and ethnic demographics? What is the gender distribution? What are their comorbid or co-occurring disorders that are found within that population that also got diagnosed in them? And then for those who did appear to have OCD, either formally diagnosed or identified by content of the note material, we wanted to find out what treatment they were getting, right? What percentage were getting ERP? What percentage were getting cognitive behavioral therapy in a general sense, even if it wasn't specified what technique it was? What percentage were getting medications? What percentage were getting the combination, right? So really as broad a possible look as we could at a very, very large sample. In this case, the database was over 10 million people. And it allowed us to collect and obtain data from the largest sample of people with OCD ever studied. Even somewhat bigger than the big worldwide genetic study that came out last year.
Mm-hmm. So it was like this real world study using data of real folks who go into clinics and talk to physicians to get, like Becky said, a baseline of where we're at with treatment, but kind of to get into the more nitty gritty, like, who is getting diagnosed? What are the rates of OCD recognition? Who gets actual diagnoses? Who maybe just has a note in their chart that says they exhibit things that are similar to what I would conceive of OCD, but, not necessarily an official diagnosis. And then also, beyond recognition, who's getting what treatment and how are they getting that and how often are they getting that? We have a question in the chat from Bridget, which I feel like is relevant because Sanjay mentioned EMR, which, is an acronym that may not be familiar to everybody. So can we talk a little bit about this data set?
Yeah. So the data set that we were able to access is from Guardian Research Network, and that is a network of 14 health systems. Most of them are community-based health systems. I think one of the 14 is an academic medical center, and they are collected from across 16 different states. The population of patients, however, is from all 50 states. So it probably includes some people who are getting telemedicine visits during that period of time, or who traveled and were getting their healthcare in a neighboring state, let's say. So while the network itself is based in 16 different states, the overall population, we were getting people from all over the United States and including the territories.
And for insurers, all types of insurers were covered.
Yeah. So public and private insurance. Yeah, and the population was very similar overall to what we know about the U.S. population based on census data. The network is not perfectly representative, but it's mostly representative. So the distribution, for example, of people in different socioeconomic status brackets was nearly identical to what is in the United States. The racial and ethnic breakdown mostly was representative. I think that this database underrepresents Asian American people and Hispanics. And because it's a healthcare database, as you might expect, it overrepresents elderly people because they're the prime utilizers or major utilizers of healthcare, and it underrepresents kids. But still, the advantage of this is that if you're starting with 10 million people, you have enough power, statistical power, to really answer these questions and compile much larger samples of your, in this case, target populations of people with OCD.
It sounds like you guys are satisfied with the representativeness of the sample.
Yeah.
Yeah, that's great.
And I guess before we get into the
I just want to mention just Guardian Research Network is a nonprofit organization. They've been an incredible partner with us on this project, and I just want to give them a shout out for that as well. Sorry to interrupt.
No, you're totally good. And it just sounded like they compiled a really incredible database for this sort of work. And like when you were going to analyze this data set, what were kind of the hypotheses of what you might find based on what had been found previously?
Yeah, as I said, we had data from a handful of previous studies that have looked at the percentage of people, let's say, within the VHA, Veterans Health Administration system, who were diagnosed with an older study looking at Bay Area Kaiser patients and looking at the diagnosis rates there. We had data from single states like New York State's Medicaid data, so looking at just the Medicaid population within New York or within Florida. All of those studies were showing relatively similar findings, which is that the percentage of people within those big healthcare databases who are diagnosed with OCD is way smaller, sometimes only a tenth or less than a tenth of what we'd expect from population-based studies, where we're actually going out and surveying the population to find out who meets criteria for OCD. Right. So we expected to kind of replicate and extend that finding, and to find out, okay, well, let's update it and let's look across the span, right, in public and private health systems much more broadly than those previous ones. But that was the first hypothesis, is that yes, the diagnosis rate is going to be considerably lower than what we would estimate and what we know from population-based epidemiological studies. So we wanted to catch what percentage of people that we know have OCD or can estimate have OCD from the population-based studies are actually going in, getting a healthcare assessment, getting diagnosed with OCD. Another hypothesis was about treatment. We know from previous surveys of people with OCD what types of treatment they get. There are surveys both in the United States and abroad about what percentage of people with OCD get CBT or exposure and response prevention. There's a VA study as well, finding that I think only 3% of the patients diagnosed with OCD got ERP. Right. So again, our hypothesis is that the percentage of people who are getting true gold standard treatment is probably extremely low.
But again, we really didn't know how these results extended to the whole country.
And across the lifespan.
And across the lifespan. So, and with the sort of statistical power to parse out demographics. But okay, anyway, so Becky, I'm going to throw it to you because I feel like I've been giving Sanj too much air.
Fine by me.
I feel like we've set the stage. What did we learn from this analysis?
Sure. I mean, just to summarize it, up to 10 million Americans have OCD based on the prevalent rate of up to 3%. And just a very tiny fraction, about 1 in 6, are getting a diagnosis based on what we learned. And
about 1 in 6 of the people who have OCD. So only 3% of Americans have it, and only 18% of those 3% get the diagnosis.
Yeah.
Correct.
Yeah.
And then in addition to that, an even smaller fraction are getting what we call the gold standard treatment, which is ERP, either with or without in combination with medication. So that means 95% of people in the US with OCD are not getting the most effective treatment. That's a staggeringly high number.
Yes.
And, coming out of that, there are other findings we'll share in a minute. If this was another illness that was this common and this debilitating, that simply would not be tolerated. And it has been tolerated. And it's, I think, in large part because of a lack of awareness and understanding of the drivers of those problems. The white paper, in many ways, for this community, it confirms what we know, right? Or Sanj just laid that out very clearly. But what it doesn't share is for people in a position to make decisions and make changes on what actually they could do to move the needle and improve that number dramatically.
Yeah, but that 95% figure is astounding. Oh,
yeah, as you said, staggering. That and alarming. What are your thoughts about why we're seeing such a large disconnect between the evidence-based recommendations and what's actually happening on the ground?
Yeah. So Sanj can speak to that as well, but I think, what's maddening is that effective treatment exists, like very well-established, well-proven treatment, and people just simply aren't getting it. And there are a number of factors that play into that. One of the biggest ones that's highlighted in the paper is about clinicians, whether they're mental health clinicians or otherwise, simply don't have either the awareness or the training to do an appropriate screening. And if they're in a position to refer to treatment, aren't referring to the correct kind of treatment or referring to treatment at all. And then even those who are possibly treating people haven't been trained appropriately to do ERP, or they have concerns and competence issues around doing ERP because it's a nuanced therapy. And Sanj can talk more about that. I'm not a clinician. Don't try to pretend to be one. And so that people with OCD are being failed at every step. And that's a major, major issue that needs to get fixed. I think additionally, like I just said, there's a very low awareness of what OCD is as a serious and often debilitating mental illness. It's obviously covered a lot in pop culture, and there's these misunderstandings that we know all too well about what people think OCD is. But very few people who aren't having a direct connection to OCD don't understand the suffering. And that goes on for people who are struggling with it. And also people who may not even know themselves that they have OCD, even if they're struggling with those symptoms. So Sanj, I'll kick it over to you to get into the part of it.
Yeah, I mean, I think one is to just understand what the findings are in this study. And then secondly, to think about what are the drivers of that? And we have information from previous studies about barriers at every level. And I think there are multiple different levels, as Becky's alluding to. Number one, many people with OCD, we know from multiple prior studies, don't even go and seek treatment, right? So a bunch of that, percentage of people with OCD aren't even going in. They're not talking to clinicians about it. They may not even be aware that they have it and they wouldn't be detected unless they were screened. And even for those who suspect or know that they have OCD, they often don't get help because they're not aware of what help is available, or there are barriers to treatment seeking and to access. So cost is a major barrier. Lack of availability of qualified clinicians who know how to diagnose and treat OCD, that's a barrier. Lack of insurance coverage is a barrier. Stigma, very big barrier. Right? Even family and cultural factors that inhibit people from talking about mental illness, from revealing their symptoms, right? Tremendous amount of shame and embarrassment, all the factors that we at the IOCDF and all of you in the broader community have been fighting for many years to try to reduce. Once people actually seek treatment, then the next set of barriers, right? So they're not being routinely screened for. In primary care offices and PDFC screenings for depression, GAD, generalized anxiety disorder screenings are now a common part of primary care visits. But I'm not aware of any primary care settings that screen for OCD. Even within mental health settings, people will do their initial evaluations focusing on mood disorder symptoms, anxiety symptoms, psychotic symptoms, substance abuse. Very often they never even ask somebody about OCD symptoms. They're not there, even mental health professionals who should be aware of how common it is. When you think about, we mentioned up to 3% of the population, but within mental health settings, it may be up to 10%. So previous studies have looked at, what percentage of people who are in mental health settings, inpatient, actually somewhere between 5 and 10%. So we talk about, could you imagine in any other branch of medicine, 10% of that population not being screened for and often not going untreated? So we're talking about a major component of the population of any mental health database. So failure of screening, and then failure of comprehensive evaluation to make a diagnosis. So we know from previous studies, a lot of people will get diagnosed with non-specific disorders, like mood disorder, not otherwise specified, anxiety disorder, just in general, not otherwise specified, because the clinicians are not going through and determining, wait, do they have OCD? Do they have panic disorder? Do they have generalized anxiety disorder? They may not have even been trained to assess it and know what questions to ask. And then the next step, as Becky was talking about, is that even when they do get identified, and even when they do get a diagnosis, or as you pointed out, the notes say, yeah, this person might have OCD, or they're talking about intrusive thoughts, referred. So in our results, when we look at the overall population, 3/4 of the people who got either diagnosed or detected, identified as having OCD, still were not referred for CBT or ERP. More than half of the people with OCD identified in our study did actually get a mental health assessment within the network. So we actually have documentation of their mental health assessment. So the networks don't include a lot of outpatient private practice, right? So they're not going to have data from people's outpatient therapy practices, solo practices for psychiatrists and things like that. They're composed of data that's from health systems. So, but again, more than half of the people did get a mental health assessment, and the numbers are somewhat better. So the rates of referral are a bit better, maybe, but still more than half of the people aren't even getting referred for CBT or ERP. Even when we can document that they did get a mental health assessment within the network. We have the data, and they still weren't getting. So overall, only 2% of the 72,000 people that we identified as having either fully diagnosed or detected OCD. That's the biggest sample of people with OCD ever, examined in the study. Only 2% had documented evidence of receiving ERP, exposure and response prevention. Now we know that a lot of times, especially in the notes of non-OCD clinicians or non-therapists, right? They're not going to necessarily list that this person specifically was getting ERP either, but they do list CBT. A lot of people will just mention that the person's getting CBT or they're doing CBT for OCD, and it may or may not include exposure and response prevention. We didn't have the means to really examine exactly what type of therapy the people were receiving, because a lot of times they may have been referred out of the network, right, to a specialty therapist or a private practice therapist. But at least we could, and so if we use CBT as an umbrella term, still only 19% of the 72,000 received CBT.
So 2% is what you said were
documented as having exposure and response prevention. And we know that of that 19% overall that got some type of CBT, probably some of them, maybe a lot of them were getting exposure and response prevention.
But it's just unclear.
Probably not all, right? Yeah, because we know from previous surveys, even of people who work in anxiety disorder settings, psychologists and other mental health professionals who've been trained still, oftentimes they don't recommend or provide exposure-based therapies, right? Even when they know that that's the gold standard treatment, they still don't do it. So again, multiple different barriers at all different levels along the chain, from initial recognition or awareness about symptoms, maybe I have OCD, maybe I should go get help, what treatments are out there, to screening and assessment to make a rapid and accurate diagnosis, to appropriate referrals for gold standard therapy, which in many cases, especially for kids, is the first line of treatment, right? Even before medications, you're supposed to refer for behavioral therapy, depending on how severely ill the person is and how many comorbid disorders they have. And so even the folks who are getting mental health evaluations, still, most of them are not getting referred appropriately for evidence-based therapy.
And I guess another barrier that I'm not sure was addressed is, like, you are referred for ERP. That doesn't necessarily mean that you are doing ERP or you go do it, right?
That's right.
Right.
Yeah.
You can't, a lot of people couldn't access it. Maybe there isn't a person in their area or within their health system coverage network that offers it, right? Insurance companies sometimes will have a panel of therapists whom they cover, and they'll say, oh yeah, these people can do treatment for OCD, but when you actually go and talk with the therapist, they don't do ERP, right? I think virtually every person I've ever spoken with who had OCD and had sought treatment has run into this problem, right? Of seeking help from a psychiatrist or a therapist, psychologist in the community who says they can treat OCD and have had experience with it, and then they're not doing the gold standard treatment. And sometimes they don't even mention it. So I'll say, oh, well, did you receive exposure and response prevention? They'll say, what? Clearly not. Yeah.
John, as a clinician, I mean, how frequently do people come to you and say, oh, I've done therapy for OCD, and then they haven't done ERP?
Yeah, well, a lot of them say that they've never, done ERP. And unfortunately, a lot of them say that they have tried ERP. They say it didn't work. And when you really ask them about what they did, it wasn't good ERP. And so people who are saying, clinicians who are saying that they're doing ERP are not really doing good ERP. And I'm glad you asked that, because that's exactly what was going through my mind as Sanj was talking. OCD is such a complex and misunderstood condition. And the therapy, like, in order to do good exposure and response prevention for OCD, you have to really understand, so much. You have to understand OCD. You have to understand how OCD is playing out for that individual person. I think a lot of people just think, oh, let's make a list of what the person's afraid of and just, one after the other, just, exposure. And that's not what it's about. And that's not going to, if you do it that way, that's not going to help people. And so, we're facing, that as part of the barrier also, that this is just, it's a complex problem, and the white paper speaks to this to some extent, better training for clinicians to understand OCD, to understand how to implement treatment. It's tough. It's a challenge, even under the best circumstances, to do treatment for OCD. Not everyone's trained how to do it.
But the results of the study aligned perfectly with my own clinical experience. Over I probably treated over 1,000 people with OCD, in specialty centers, right? Running OCD clinics, seeing outpatients on a weekly basis over many, many years, and that's what I was seeing. So even in specific clinics like UCLA Anxiety Disorders Clinic, UC San Diego OCD Clinic, when I was getting patients in, the vast majority of them, including the ones who already had it coming in, a diagnosis of OCD, had not been either referred for exposure and response, knew about it, and were hunting around and trying to find a therapist, and then never received it.
Yeah.
When I worked in an intensive treatment program, most of the people had tried some sort of therapy. The majority of them had not actually had an adequate course of exposure and response prevention. And yet they were ill enough to be referred to an intensive treatment program, and they needed the intensive treatment, but they hadn't even had the basics yet. Yeah. So the results are not surprising, they're just shocking.
Yeah.
I'll add to, building on both of those points, is that it's important, it's not clinicians' fault necessarily. Clinicians want to help people. They want to help people with OCD, but in most cases, even if, like Sanj said, even if they know what the professional standards are, they're not equipped, often not equipped or trained to do it. Or even if they have been, they don't necessarily have the confidence to carry it out because, like John was saying, it's complex. And it takes that additional training and mentorship to be able to do it. And so I think those are areas where we really need to offer those supports across the continuum of expertise and experience that clinicians have, all the way down to primary care, pediatrics, that frontline treatment that people are getting, those screening tools that we offer. They're on our website now. Someone can flash the URL up in case folks are interested. That's where that becomes so critically important. And then just continuing to provide trainings. And we offer trainings at the foundation at the level that we can. There are other great training programs out there. And I think that's where we start to get in the awareness piece. If there are pieces around, requiring more training for OCD through graduate programs, make it contingent on licensure. Can we work with professional organizations like the APA to make sure that we're very clearly showing what the professional standards are? Should we ask government to require that those professional standards are adhered to? Those are all the types of things that we're discussing now, is how we can start to move the needle on all of those complex issues.
Yeah, I mean, if you want, we can go into some more of the striking findings or some of the additional results, or we can talk a little bit about recommendations, because based on all the different findings in this study, our team developed kind of 4 main categories of specific recommendations. And if you read through the white paper, those recommendations are directed towards different groups. And because, as we talked about, the problem that leads to this striking gap in diagnosis and treatment is multifactorial. I
feel like it's about as good a time as I need to transition into some of the recommendations. What you said, Becky, there about being able to work with accrediting institutions and find a way to kind of formalize this sort of training is a really interesting thought. It also, just before we get into the kind of structured findings that you guys have, I want to mention Amy's question, just because I'd also never really thought about it. Are there any steps, is that 1208? Are there any steps being taken for those who claim to be OCD specialists rather than just allowing any therapist to say they are? I think this is kind of what you were alluding to, right, Becky?
Right. I might feel more comfortable if Sanj or John want to field that in part, because I think the IOCDF has no control over what therapists or specialists are saying or doing in their practice. We can only continue to advocate for and promote and disseminate what the best practices are and point them to resources for better training, et cetera, et cetera. But I'll let John and Sanj talk about that, because I know there's strong opinions about claims that some specialists make when they're not appropriately trained.
Right. This happens a lot. I got kind of a 2-part answer. Number one, the ICDF has a resource directory, right? So that Find Help search engine on our website, and it lists, I think, like 3,600 or something, close to 4,000 clinicians across the U.S. In order to be in the resource directory, you have to put in information about the nature of your practice, what type of training you had, did you have experience in learning and practicing exposure and response prevention, what types of patients have you seen, what percentage of your practice might be including people with OCD and related disorders. So even though there's no formal accreditation in the United States or board certification for being an OCD specialist, the information is there, and people can compare different therapists based on what the clinician has put in as to their qualifications. There's a difference between, I took one training, I completed the Behavioral Therapy Training Institute, versus I've been a faculty member at the Behavioral Therapy Training Institute for 10 years, and I've seen 400 patients with OCD and treated them with ERP. Right? Mm-hmm. Obviously, very different level of expertise and experience. Canada and the Canadian Institute for OCD is actually working on an accreditation process. And this is a long-term project where, number one, they develop competency and knowledge standards for both adult populations and pediatric populations, for both pharmacotherapy with medications and cognitive behavioral therapy. So those were written up and published about 4 or 5 years ago. And they've been developing training modules that can be disseminated to get people the training to reach and achieve those knowledge and competency standards. And what they next want to do is to have a system of accrediting training programs to say that, yes, this training program is training people sufficiently. So
they're accrediting training programs, not clinicians themselves.
They want to do both. Yeah, but again, I think this is in the early stages. They're still developing the training modules. They're a ways away, years probably away from having a setup to actually certify clinicians or accredited programs.
From time to time, this in the different organizations that I've been a part of, including IOCDF, this has come up. Like, is there a way to, accredit or certify people? And there's pros and cons to it. And obviously, it hasn't happened. So, but it's an interesting idea, and might, if it could work out, might be a way to help with some of this.
I think I also want to mention with the resource directory, well, again, not putting the burden on patients, but we do try to provide a lot of information on how to interview your potential therapist, what questions to ask, how can you suss out, like, do they really have the experience, especially if you're a parent looking for treatment for your kid. There's a lot of information to help guide you in that process. We just updated our resource directory, and there's more filters and how to screen for things like culturally competent care or things that are important to you, what type of insurance are accepted or not accepted, just to help to guide and drive you to those people. But like Sanj was saying, we have a very good resource directory, but there isn't, it's not very big. It's as big as it can be, but it's just, there's a lot of gaps out there. And I just want to come back to the question that you brought forward to, Kyle, is that, like I was saying, there are things we can do to try to force to those professional standards, make it required that graduate programs or other training programs are including more information, more time, more hours of study about OCD specifically. So there are other ways to get at it, but I kind of fully agree with what Sanj and John are saying about, the accreditations or certifications. I think would be a very clear way to do that. But in short of that, there are other things we can do.
And your point about the importance of asking a provider, and someone mentioned Connect for OCD at 1236, that some clinicians seem to feel insulted if you ask them. That's not your problem. You've got to ask. You've got to stand up for yourself as a consumer. If a clinician feels insulted that you're asking about their training, maybe that's not the clinician for you. But at this point, it is important for consumers to look out for themselves. It's kind of buyer beware at this point.
And I just will echo that further, John, especially if you're a parent advocating for your child, but even for yourself, like if I was getting treatment for a different type of illness, I would get a second opinion. I would make sure if I needed surgery, I would want to make sure, am I meeting with the best qualified surgeon for what I need? And people can be insulted or not insulted, but it's your health or your child's health.
That's right. That's right.
Yeah. And this is why we have recommendations at different levels. So, number one, raising accurate awareness of OCD, what it is, what it's not, so that people can recognize symptoms in one another or in themselves, and then what the treatments are, right? Vast majority of people in the United States may not have even heard of the phrase exposure and response prevention, may not know that there is a specific form of cognitive behavioral therapy that's the most highly effective for OCD. So then they don't know what to ask, right? They're not going in and saying, oh yeah, I'm looking for an ERP provider. That's, if they've read a lot and become educated on this, then they do that. But there's a huge number of people who don't have that background. They have no idea what type of treatment should be given, so they don't know how to ask for it. So raising awareness across clinicians, family members, the general population is going to be really important, and increasing investment in initiatives that accomplish that goal of increasing accurate understanding and knowledge of OCD. for educators in school settings, the general public, clinicians, all of those needed.
Yeah, so I guess I was wondering, we have this information now from the white paper that says, 3-ish% of folks in the US have OCD. Far too few are diagnosed with OCD. Far too few of those people actually get treatment for OCD. What can we do? Like we talked about screening therapists and like maybe the patient taking some onus and asking the therapist, do you do ERP? Maybe some sort of accreditation, but like what can the IOCDF tangibly do, and what can we as community members tangibly do to stop this?
So as I said, we kind of have 4 main categories of recommendations. So one is the one I just mentioned, raising awareness, right?
Yeah, but how do we do that?
Yeah. So ICDF has been involved in raising awareness for nearly 40 years now. Public awareness campaigns, things like OCD Awareness Week in October. We're calling for increased funding for public service announcements, for other awareness events, to get it more into the media, more into public knowledge, and particularly in other settings. So we have some recommendations for support and funding for more awareness campaigns. If you think about big awareness campaigns, even things like the ALS challenge, that bucket challenge for Lou Gehrig's disease, right? Just that whole set of TV commercials and the viral bucket challenge raised awareness of an extremely uncommon illness.
Yeah.
Right, ALS. Here we're talking about a pretty common illness, but misunderstanding, stigma, and so forth are barriers.
Can I just add to that really quickly, Sanj? We have a robust advocate program of people from around the world with lived experience with OCD that share their stories through their communities. Yeah, including you, Kyle. And thank you for your volunteer work in that. We have affiliates throughout the U.S. We have numerous global partners. So there's lots of channels that we can work to raise awareness. And in addition to all those Sanj said that are bigger scale things, it's just having conversations. I think it's sharing your story, whether in front of anyone in a position of authority that might be able to make decisions that could change it. If it's talking to your pediatrician's office, if it's talking to, any setting that you're in, raising awareness, sharing the paper, even if you don't talk about the IOCDF, I think it's just sharing that this is a common illness and so few people are getting connected to the treatment that they need. Makes a big difference. And our burden is to start, that's what I said at the top of the show, we need to reach so many more people who don't already know about us and don't already have this information so that starts to catch fire.
Yeah. And this is where we've seen an uptick in celebrities and people who are well known in the media talking about their OCD. I mean, just in the last couple of years, pro football players in the NFL have talked about their OCD and done interviews about it. Actors, musicians, right? Just recently, Eddie Murphy's documentary talked about his experience. Amanda Seyfried, lots of people. So the more of these prominent people who are in entertainment industry, sports industry, and so on, talk about their OCD, talk about the symptoms, and getting treatment and advocating for treatment, the lower the stigma hopefully will be. And we're getting at one of the barriers. The second big category of recommendations is training. Right. If you talk with at least master's level clinicians who've done a master's of social work or a master in family therapy, or counseling level clinicians, professional counselors, clinical counselors, what they'll tell you is that they had hardly any mention of OCD in their training. Certainly not any training in how to conduct exposure and response prevention for OCD. So one of our main recommendations is that all clinical mental health training programs, psychiatry, clinical and counseling, psychology, social work, marriage and family therapy, counseling, must provide adequate training in assessment, diagnosis, and evidence-based treatment of OCD that includes exposure and response prevention. I think there's just no excuse for training programs not to do that.
Yeah.
In my view, the training is not matching the public health need.
I can tell you from my own experience that the medical school curriculum really doesn't mention it. So if I were a primary care doctor and wasn't going into a psych residency, I probably wouldn't know to screen for it. John, I'm curious, as someone who spent a lot of time in clinical psych departments. What kind of recommendations do you think would be like a tangible thing that universities might be able to implement?
Yeah, that it's going to depend on the faculty that are at each institution, but then again, you do have access through IOCDF and other such organizations, so it really shouldn't depend on that. We have students go through clinical practica when they're in PhD programs, and they have to do a certain number of hours of training before they can apply for internship and go on, get their PhD. And in the past, there hasn't been a requirement. You got to have this number of hours of depression or things like that. But making sure that when programs are accredited by the American Psychological Association, for example, if they're looking for that, there's good training in empirically supported treatments for OCD.
Yeah.
So I don't think it's going to the programs and saying you've got to do this, but maybe going to the bodies that accredit those programs and say you should be looking for your training programs to offer training in exposure and response prevention, things like that.
And that's the corollary to the what's happening at the curriculum level is we have a specific recommendation for accrediting bodies to ensure that if they're going to accredit a training program in whatever discipline in mental health, it should have adequate coverage, right? So the graduate medical education has accreditation for psychiatry residencies and all other residencies, and they have specific requirements. They'll say, yes, in order to complete a psychiatry residency, every program must require demonstrated competency in such and such disorders, pharmacotherapy, 5 types of psychotherapy that include CBT, right? Those types of requirements should be there at all different levels by the accrediting bodies.
The psychiatry residency accreditation bodies are even stricter than the psychology programs. The APA will not. We have tried for years to try to get them to be, you can only, like, if programs aren't doing empirically supported treatments, they should not be accredited. And our own APA won't do that. So you guys are even more strict than we are.
Wow, interesting.
Terrible, right?
And when you go to the master's levels programs, even with people in our training faculty on our scientific and clinical advisory board in the past have approached graduate schools and accreditation bodies and met with a lot of resistance. That's one of the things we're hoping to help overcome, really with public pressure with this white paper, is to push accreditation bodies. And then the next level up is clinical licensure, right? So after training, people have to do a certain number of hours, additional training in order to get their licenses, and they have to take exams. You get board certifications for psychiatry, there are certifications for psychology, licensure exams for all of those. What we're calling for is that licensure boards should make sure that their exams and their requirements for licensure in each state include demonstration of competency in assessment, diagnosis, and treatment of OCD.
Mm-hmm.
So at all different levels, we're looking to improve training and promote adherence to the professional standards. We've had practice guidelines for a long time. The initial practice guidelines from the American Psychiatric Association came out in 2007, clearly putting cognitive behavioral therapy that utilizes ERP as the first line most recommended treatment. But it's 18 years later, and we know that people aren't getting trained. And secondly, even those who have the training are not doing it. So even after the training process, the accreditation, the licensure process, there has to be something in the field in general that ensures adherence to professional guidelines. Mm-hmm. I've made this point before that in the medical field, if you go in for treatment of disorder and your clinician gives you a treatment that we know is not effective for that disorder, or they don't even talk about or refer for the appropriate treatment, they would get sued for malpractice. And yet that doesn't happen that I've heard of in therapy fields, right? All these therapists are out there doing non-specific therapies, non-exposure-based therapies, non-CBT therapies for people with OCD that we know don't work. Nobody's suing them.
And I just being cognizant of time, I think we have 2 more recommendations left, right?
Yeah. Just one more, because the adherence to professional standards was kind of third. We got training, awareness, standards, and then a specific one for clinicians and health systems is to conduct routine screening for everyone who comes in. So, and there are very, very quick screeners. We have them available on our website, and the white paper refers to them. That are 4-question brief screener for adults with
just 4 questions.
5-question screener. Yeah. So these are very brief, very easy to do. They've been well validated. They have, I think John has been involved in these and developing these ones. And
let's go, John.
Right. So they're brief, they're doable, they're practical, and they have high sensitivity and specificity. If somebody screens positively on one of those, the child one or the adult one, they should then be referred to a mental health setting to get a comprehensive evaluation. And if somebody's in a mental health setting, not only should they be getting screened, but they should be getting the full assessment to make an accurate diagnosis of whether the primary disorder is OCD or they have it concurrent or comorbid with other disorders. And then thirdly, they should be referred for treatment. So, we call for dissemination of routine screeners in all the health systems. We're calling on the people who run clinics, run hospital networks, run practice networks to make sure that their clinicians have the tools to be able to do routine screenings and to incorporate that into their everyday practice.
And Becky, I know you have kind of experience in operationalizing stuff like this. So, how do we go about kind of starting these changes?
Yeah, I mean, from the foundation's corner of the store, our virtual store, it's just I mean, it's about relationship building, and it's not just with the APA or accrediting bodies, and we need to do that work too, but same with policymakers. We have to reach out, build relationships, try to have meetings, try to have conversations. Now we have new, very relevant data that will very much support what we've been saying for decades, right? What many of us have been advocating for decades. I think secondly, it's just we have to have a little bit of a stronger voice. Our role is to advocate on behalf of this community, and the IOCDF has done that very well for a long time, but we have to be a little bit more pushy, I think, for lack of a better word.
I'm cool with that. I'm very pushy.
So I think that's just like owning our space as like the nonprofit that's the leading authority in this space and really fully representing the community in the many ways that we're trying to do that.
Mm-hmm. I think, kind of in reference to putting the paper, something that Sanj said that I liked a lot was it's going to have to be kind of like a public pressure-y type thing where, more people know about OCD, more people see these treatment gaps and get frustrated and force people to do the action that's necessary to be taken.
Exactly right.
Exactly right.
Yeah, which is why it's important to be doing live streams like this and putting out papers like this. I kind of want to end the show in a way that I've never done before. But John, you've been a researcher in this field for a super long time. When you read this white paper, was the first couple of thoughts that you had?
Yeah, well, I'm glad you asked that because I had kind of thought about that. I was, as I said, just kind of blown away by the numbers of who is getting the right kind of treatments. I think that kind of takes the cake for me. When I got into this field in the 90s, there wasn't a lot of, there wasn't an internet the way there is now. And it was primarily in the universities where ERP was being researched that people were getting the treatment. And we were working very hard to disseminate that. And it's a little heartbreaking that we haven't had as much of an effect as what would have been hoped. Now, 40-ish years later, it's kind of hard to say that number. It's a long time. But yeah, that's what really, if I had to boil it down to one point, that's what jumped out at me.
And I just wanted, so we're not ending on heartbreak, because there's no question these numbers are tough. And when you look at some of the demographic data, related disorders, which we weren't able to touch on, I mean, it's really rough, right? I mean, it's very, very disheartening. But what I'll add to that is like, we have all the ingredients to bake the cake, right? The IOCDF has, and it's not just us doing it alone, right? But there is training. We do have evidence-based treatment. We know what needs to happen. And now we even know better, who needs to help us make those changes happen? These are fixable problems.
Yeah.
I think it's just, we can do that work together. It will take time. It won't be easy, but it is possible to make change.
Yeah. And I will say, you know, one positive finding was that we're doing much better as a nation or health system on the medication side. 65% of the population that we identified as having OCD by diagnosis or otherwise were getting treatment with serotonin reuptake inhibitors, and a couple percent with clomipramine. So in terms of people getting first-line appropriate medication, like we weren't able to take a look at dosing. And we know that many people with OCD are underdosed, right? Where they're getting the lower doses of SSRIs that are appropriate for broader anxiety disorders and depression, but are not sufficient for OCD. But still, just to find out that at least 65% of the OCD population was getting the right class of medications was heartening. I think the real gap is exactly what John was pointing out. The big finding that jumped out to all of us within the foundation was the failure of referral and receipt of ERP and CBT more broadly.
Yeah, but all the more reason to scream from the rooftops.
Yep.
As an IOCDF advocate, or as a grassroots advocate, or someone living with OCD, or as a child with OCD, or a friend with OCD, to start having these conversations. John, I'm sorry that I had to break your heart twice by making you talk about your past life as a researcher in the 90s, and then remembering that was 30 years ago. But thank you both for being on the program. Thank you, John. And the white paper is online. You can go ahead and read it. We've talked a lot about it. There's actually like a number of findings that we didn't have time to touch on that are also interesting about kind of gaps in demographic groups and in terms of OCD identification. We will be on next month with a different topic. But in the name of this stream, don't stop talking about OCD.
Well said.
Thanks so much for having us. This was great.
Thank you.
Thanks, guys.
Yeah.
It's a great conversation.